Thank you, Hashi. First of all, thank you for this initiative. I can say like that because it's very it's amazing for us to be like together, far and together at the same time. This is what pandemic brought to us. So we are here so far but so close at the same time. So I'm going to introduce myself. I'm Sandra Bastos, as she already said, and I am a doctor for already 20 years, but an ENT doctor since I forgot now, 14 years already that I am ENT doctor, and running basically patients with tinnitus. I think I have around, I can say like 10 years more or less. But I was like, because in the beginning when I was starting to work basically with this, I started basically with patients with balance disorders. And then after I would say like 5 years, I started working much more with tinnitus patients. And I first went to Hashir's course in 2015. And when it was like an open mind idea how to deal with patients, tinnitus patients. And since then I focus much more with tinnitus patients, and I'm basically working through this time just with tinnitus patients. And it was like a challenge to me because I like very much challenges. And that in that time I was not like I did something like more challenging for me. So I would it was like that. So what to do? How can I help much more patients? So I got like more or less in love with this idea about CBT, and I started doing with no fears. But I have to say that Hashi helped me a lot at that moment. And then it was, you need to like to keep studying and keep trying on patients. And the results shows to you that you are like that you can do it. So that's it.
And then you had this starting point with the doing the CBT, which started from the My Tinnitus Masterclass. But then every year you updated yourself and went to different CBT courses in other places, and kept yourself up to date with that. So it's like an ongoing process of learning
Yes.
and enhancing your
Exactly.
skills.
Yeah. I never stopped. Yes, because I here in Brazil, I'm always like in touch with people people in meetings and books and everything. Because it's not enough. Like you keep like you need to keep yourself studying all the time, right? But in the same time, I would say that the master class was like the open mind, and I went twice already. And I was supposed to be like in the third one, but the pandemic avoided us to do it. And I think every year that I went to that, for the second time that I went, it was like it was more, it was like you will learn more. So because with your background, with your experience, so you just join, you gather what you have as practice, and you listen Hashi once more. So it was like important for me, but I have to say that I keep like studying and I keep myself going to meetings and reading and listening and everything, like to learn to feel more confident with the patient. So when I see tinnitus patients nowadays, I have to say that I don't have no fear. I exactly know what to do with him. But the problem is if he wants me or if they want me to do what I want to do with them. This is the limitation, because we know what the patients need, but if they don't want to, this is another problem.
Exactly.
So
They
yeah.
often, anywhere that I see the patients, they don't really come to me and say, oh, please show me how to do CBT. The main thing that they want is to get rid of the tinnitus, and
Yeah,
which is understandable. And so from that starting moment that patient walks into the clinic, there is a gap between the expectation that they have and what actually we can offer. And
exactly.
so a lot of time needs to be spent on bridging that gap with them and enhancing their motivation and preparations for the therapy as you do. Thank you very much, Sandra. And Anna, would you like to introduce yourself and tell us a little bit about your practice?
Hello to everybody that are watching us, and thank you, Hashir, and thank you, Sandra, for participating in this event. You know, I was very excited when you invited us. I'm an ENT specialist and an otosurgeon. I'm working in a clinic for otorhinolaryngology and maxillofacial surgery in Belgrade, in Serbia. And, you know, most of my patients are ENT patients, patients eligible for surgery. And tinnitus is one of their really frequent complaints. So I wanted to help them with it, you know, wanted to solve their problem. So I entered the course. And like Sandra said, you know, I didn't know what to expect. I was reading about CBT, but I didn't know what to expect. You know, it's radically different than everything we've been taught to do. You know, ENTs, we examine the patient, we're doing diagnostics, we're operating, and, you know, problem is solved. But this is a totally different approach to solving things. You know, you have to listen to your patient, you have to work with the patient, you know, consulting them, you know, the sessions, you know, ENT exam like last 10, 15 minutes, 45 minutes with them on these sessions. So it was really quite a challenge for me, especially in the beginning. And, you know, first we had Hashir, and I had, probably Sandra also, had some one-on-one consulting sessions, you know, talking about some patients that I've been seeing. That was really helpful. And then after, you know, when I got more experience, when I got, you know, more patients, you know, the perspective changes. So that was what Sandra was talking about. You know, when you come back to certain things, you know, you look at them a different way with much more experience, you know, about the problem. So, you know, the course was very helpful. And then after that, you have to, you know, keep working, keep seeing patients, you know, to see different situations, different ways of approaching the patients and relieving them of their tinnitus distress.
So this is like the starting off with the theoretical aspects of it, doing the course, and then you started seeing the patients, implement that, and at the same time having the sessions, one-to-one sessions, going through the patients, making sure that basically what you're learning you can apply properly in the clinical environment. And so basically learning from our own errors, if you like. And
yes, you know, it's important, you know, it's important not to be stuck with a patient. You know, at one certain point you have to progress during those sessions. You know, you have to make some improvements, and the patient has to accept those things. You know, you've been telling him, he has to realize a lot of things, you know, and change his attitude towards tinnitus. So it's a process, yes, and for us and for them.
Yeah, if I can say something, Hashi, I remember once when I was watching one of your appointments, and because I was trained to listen to the doctor, and in that moment I was listening to what Hashi was asking, and at the end of the appointment, Hashi asked me, "What did you listen? For one, did you listen to?" And I said, "To you, I was paying attention to of what you were asking to the patient." And he said, "For the next one, you are going not to listen to me. So forget everything that don't listen to me. So just pay attention in patients' talk." So that thing was like amazing. And when we were like discussing afterwards, it was like oops. When I said, this opened my mind, because it's impressive how we don't listen to patients. We don't. We listen exactly what we want to listen to, like to make a diagnosis, but exactly what he wants to say as ENT. I don't know about you, Anna, but I was like shocked, because I said in that moment I realized that I was listening not enough. I wasn't listening enough. So this changed absolutely my approach to the patient. This changed everything. So, and now I'm so used to like work like this, to listen extremely what he wants to say, to tell, that I cannot like I cannot go to the other way around, you know, to be like the way that I was in the first place. So it was like something. Thank you very much, Hashir.
Exactly. But thank you for bringing this up, because you know, the listening skills that usually medical students get is very limited, and mainly, you know, focusing on making the diagnosis and the treatment and giving the instructions. And the more the listening skills in the form of a counseling, which you would do in CBT, is different, and letting the patient, give the patient that space for them to think and explore, and without having to making them correct or correcting them or pointing them at the right direction immediately. The moment that you notice something wrong, you have to kind of withhold yourself from actually telling them and let them to guide them, so for them to be able to understand that and see the problem from a different angle, and then the real change can happen then. And it is like, I can understand from the feedback from many of my audiology colleagues, as well as the ENT colleagues and other people with medical background, that when they do the course, it's quite like a crunchy gear change. So it's like a bit of a shocking to the system that you have to basically do a lot of more a different approach rather than your medical way of dealing with it. And but then, you know, practicing and discussing the cases and continuously improving your own skills. And we also have these monthly meetings with the clinical expert group, which we share difficult cases that we have and get view from one another. I think that's also a helpful means of continuous improving our efforts, if you like. The other things which are important for listeners at home to actually know is there are a lot of background procedures and policies that basically you put in place, the infrastructure before embarking on doing a therapy like this, procedures of when to refer to mental health colleagues when the patient is distressed. And in terms of the occupational health, like when you become distressed by your patients, what are the supports for you? And then what would be the best way of contacting people in terms of the on-call psychiatrist or the general practitioner who is in charge of the care of the patients in urgent situations. So there's a lot of background work is needed when you embark in offering a treatment like this. And fantastic. So I don't want to take more time of the presentation. So I know that you guys prepared a case of a patient which has an ENT clinic. So they have tinnitus combined with another ear, nose, throat problem. And so you basically had to deal with both with your ENT hat on, sorting out the problem, and also with your tinnitus practitioner hat to actually helping them to manage their tinnitus with the use of CBT techniques. So Anna, would you like to go first with your presentation?
Okay, we can go first with mine. I will share my screen now. Yes.
Yes.
Okay. Host disable participants screen sharing. Yeah. So okay, we have to do this again. Yeah.
So who is it? Sandra, can you make Anna host?
Sandra is the host. Yeah.
Oh my goodness. So what?
If you go to the right hand, if you see the box. Yes, if you see Anna's box, right hand corner, there are 3 dots. If you click on it, it says make her host.
All right. All right.
Okay. Yeah.
So I'm going to turn off my camera and microphone so you can carry on.
So does everybody sees the first slide? Yes.
Yes.
Or no? Okay. So we can start. Yeah. So again, I will present you a case with a patient with chronic otitis, suppurative otitis media, and tinnitus, and how we manage them using CBT. So this is our international clinical expert group. You know, Hashir mentioned us, and these are other participants. Also, you know, I would like to say why a group like this would be useful. You know, we have our meetings, like Hashir said, every month, and we discuss a lot about different approaches in tinnitus management. And you can see that there are 2 ENT specialists, and audiologists, and psychologists in the group. So everybody has different training in their fields and the same training in CBT therapy for tinnitus. So, you know, we face different challenges with different types of patients with tinnitus. I mean, I have more ENT patients, and patients with otitis, otosclerosis, acute hearing loss. So, you know, for me as an ENT doctor and an otosurgeon, you know, when I learned the concept of CBT for the first time, you know, it was difficult. Like I said, you know, I had to teach myself this whole new way of listening and treating to the patients. So, you know, creating this support environment between colleagues was very important during my training. And now that I have more experience, you know, these meetings help us, you know, discuss some difficult cases or some aspects of the therapy. So this kind of supervision and interaction with the therapists with experience during the training phase and later when you start seeing patients is very important. So everybody who even thinks about starting CBT masterclass should you know, think, you know, of involving some, you know, more experienced therapists to help them. I wanted, for this presentation, I wanted to present a case from an ENT practice that doesn't involve usual causes for tinnitus. First, you know, chronic suppurative otitis media. It's a disease that is not that frequent. It has a prevalence 1 to 4% in the general population. In Europe, for instance, prevalence is just 0.4%, but in other countries like South Asian region or Africa, prevalence is as high as 4%. And the disease is multifactorial. It, you know, depends on some immune system changes, genetic factors, poor living conditions, poor access to medical care, the existence of nasal disease, upper respiratory tract infections. So there are a lot of factors that could cause the chronic suppurative otitis media. And most main complaints that the patient has is otorrhea, secretion from the ear, and hearing loss that is usually conductive, but in certain forms of chronic otitis media, it can be also mixed or sensorineural type. So this is a result mainly because of the tympanic membrane perforation or the destruction of the ossicular chain or the other damage to the middle ear or inner ear structures. And tinnitus is actually quite common complaint in these patients. You know, according to the literature, percentages are up to 50% of those patients with tinnitus. And in one of a group of my patients that I was examining, that percent goes even higher to 60% of my patients had complaint of tinnitus. But nevertheless, you know, any reports in the literature are very scarce. There are only, you know, few handful of papers that are describing this. Tinnitus is one of the symptoms that is expected to improve after the surgery. You know, after you repair a tympanic membrane or you do an ossiculoplasty, tinnitus is supposed to get, you know, quieter. And that is similar to tinnitus encountered in otosclerosis, and it usually does. You know, according to the literature, it's significantly correlated to mixed and sensorineural hearing loss aspects in those patients. And according to the scores of tinnitus handicap inventory, preoperative tinnitus is assessed as mild to moderate, and postoperative, you see that there are significantly lower scores, slight to mild. And if you manage to close the postoperative bone gap, you know, and you should significantly improve their tinnitus, especially if you can improve air conduction at 1,200 hertz and bone conduction at 400 hertz. So, you know, everything should be just fine after a successful surgery. You know, hearing would get better and tinnitus would get better, and you know, you don't have problems with the patient. But actually, that doesn't happen much in practice. So this leads me to the presentation of my case. You know, it's a 33 years old male. He came to me for an exam in April in 2017. He was complaining of hearing loss, ataria, and tinnitus that he developed 13 months prior to the exam. And he used a lot of drugs, antibiotics, topical antibiotic drops, even drugs like betahistine, ginkgo herbal medicine for his tinnitus. And a few doctors before me suggested surgery, but he was successful at avoiding him, told him that he was too busy for it. But, tinnitus was present at that time. But when using medication and the inflammation, sanation, he could cope with it. This is the ENT part. We did automicroscopy, we did preoperative temporal bone CT. You can see on the coronal plane that he has a deep retraction pocket, that he has a destruction of almost all the ossicles, only the malleus was present. Also on the axial view, you have a significant bone damage because of the cholesteatoma. So we did the tympanoplasty, first attack of the tympanoplasty in June 2017, and then a second look with ossicoplasty in January of 2018. And his preoperative THI score was 24. These are the results before and after the second surgery, ossiculoplasty. This is the audiometry. You see that preoperatively he has moderate to severe conductive hearing loss, and that postoperative, when we did an ossiculoplasty with the titanium prosthesis, I'm pretty satisfied with those results. We've closed the airborne gap significantly, and postoperative he was way better because of his tinnitus. His THI was assessed at 20, and he went to regular postoperative follow-up controls and had no recurrent disease. But on one of our controls we've done in October 2019, he came with complaints about his hearing getting worse and tinnitus becoming louder, and that was irritating. And for me, as an otosurgeon, I first thought, that cholesteatoma returned, so that was the case of recurrent disease. But when I've done clinical exam and MRI with the DWI, they were without any recurrent disease, and the audiometry didn't change much. He didn't have any objective hearing loss as he initially thought. So the tinnitus was there, and it was really upsetting for him. So after a few talks, we decided to start CBT for his worsening tinnitus. When you start CBT, you have to make some initial assessments and go through some questionnaires to establish, how the tinnitus is affecting the patient, and if there are any other diseases or states like anxiety or depression or insomnia. So, he told me that tinnitus was affecting his work, his activities, his friends, and his family. THI was 44. He didn't have any problems with hyperacusis. He assessed his tinnitus loudness at 8, the tinnitus disturbance at 7, and quality of life tinnitus with also a 7. And he didn't test positive on screening tests for insomnia, anxiety, and depression. Also, Hashir mentioned you have to talk with the patient. You have to see how the tinnitus is affecting them and their everyday life and their everyday activities. You have to know about them, who are they, and who are they at work, who are they in their family relationship. You have to know their background. So these are some things, I thought maybe were important for him creating this severe tinnitus distress. He was living with his girlfriend for a year now, and things were getting serious in the past few months before he came to me. They were thinking of buying an apartment together, starting a family, having a baby, so more responsibility on that part. And he got the managerial position at work. Also, in his family, he was a second child, but he has an older sister and a mother, but his father died when he was in his early 20s, when he was in university. So, from a very early age, he was that was a typical patriarchal family. He was the man of the house. All the deciding fell on his shoulders. So that was his role in that family. And also, he gave me an information that his sister was treated for anxiety attacks for the last few years. So, it's important to understand that these patients that come and you decide to start the CBT with them, they have really pronounced tinnitus distress. When they hear their tinnitus, they have all these negative thoughts and negative emotions that they're feeling and that they are thinking of when they hear the tinnitus. And that usually results, it triggers emotional distress. It results in more negative thoughts, no more negative emotions, and it goes in circles and circles, when they the result of thinking about tinnitus increases that perception of tinnitus. The patients tend to focus more on their the stress and on their tinnitus, and at last, that's the only thing they think about. So also they tend to form some safety-seeking behaviors to avoid that emotional distress and those negative thoughts and emotions. So that can lead to their changes in their daily activities and work, and changing that can lead to more distress. So CBT is to be aimed to disrupt that circle they're in and to modify that negative thoughts in response to tinnitus. So in this case, in this patient, he complained about his tinnitus in everyday situations, falling asleep, drinking coffee in the morning at work, and he felt angry and anxious and dissatisfied and nervous every time he heard his tinnitus. And this was leading, he had all kinds of negative thoughts connected to him. He thought that he was again losing his hearing as it was before surgery, and the disease was back, and that he cannot do another surgery after 2 operations that he had, and also having more assignments at work. He was afraid that people at his work would notice his bad hearing and tinnitus, and he would be perceived as less efficient and less of a leader, if we can say that. So also, he formed some safety behaviors. As a result of all of this, he started avoiding some social gatherings in noisy environments because he perceived that all that noise is making his tinnitus louder. And if his tinnitus gets louder, he would again, lose his hearing. So he stopped going for, some social gatherings. He stopped going to some work gatherings. Also, he had this activity with his girlfriend. They were always taking a walk at the evening. So before he came to me, he even stopped that. He wasn't walking with his girlfriend because he was afraid that tinnitus would get louder because of the traffic sounds, and that will affect his hearing. So. And because of the structure of the personality he is in, he couldn't talk about his tinnitus to other people. He was embarrassed that this little thing, this little sound is, is making him think all of this, all these negative emotions, and that his girlfriend, his co-workers and friends would thought that he's weak. So all of these thoughts that he had, they're called negative automatic thoughts. And through his head after hearing his tinnitus during the day, and making him feel all these negative emotions. And we want to know where these negative automatic thoughts are coming from and why he's feeling and thinking all of this. So there are some internal rules and assumptions established across internal life and for our upbringing, and they're called rules of life. And many of us are living according to those rules. What we should do or must do or ought to do in life to satisfy the social norm. So during those sessions, you have to come and discover the rules of life for your patients. So his rules were always to be the one with answers, to be a problem solver, not to be mentally weak, to be a man about it, and trying hard to overcome all the obstacles life gives him. So not being able to solve tinnitus like every other problem he faced before, that was very troubling to him, and he was under a great amount of stress and pressure all the time, all through the day. And at the end, there is a core belief at the deepest level of cognition, according to Peck's cognitive theory of emotions. And this is, the core beliefs are really challenged with negative automatic thoughts. So after a few sessions, we came to his core beliefs. He thought that he was weak. He thought that he was incompetent because he couldn't solve his tinnitus, because he was feeling all these negative thoughts because of his tinnitus. So CBT, you know, it's you have to work with the patient together, and you have to use different aspects of CBT for tinnitus to transform this reaction that the patient has, and to transform the thoughts he has when hearing his tinnitus. You need to break the circle, and it's a painful and long process. And the goal of the therapy is not only to teach the patient the thing in another way, to more positive or neutral way, but to use those strategies and skills to apply them, all those behavioral and cognitive techniques in tinnitus management in the future, not just when he's talking to me, but in the future situations. Hashir always tells us this phrase when we were in the course. It's just about changing your mind about something. You're doing it all the time, so it's not supposed to be hard. So when you have that in mind, like CBTing yourself and CBTing the patient, everything will be okay. But we have a lot of techniques that we're doing that. So after at about 10 sessions of hard work with this patient, we've got some improvements. So these are his assessments after CBT therapy. So his THI was assessed at 26 comparing to 44. That was significantly lower. He assessed loudness of his tinnitus with a 5 and quality of his life with a 4, comparing to 7 in the beginning. So after you conducted a few sessions of CBT in the beginning, I like my patients to come back to me maybe after 3, 4, 5, 6 months to see how they're doing. So he came back for a few sessions. We've done a control for his cholesteatoma, and also we done a session for CBT to see how it's doing. And he's doing fine now. Coping. We had one session during the pandemic, as in all patients with tinnitus, these conditions, they're worsening the tinnitus and stress. It's not only on them, it doesn't fall hard on them, but also to all of us. So we had one session during the pandemic, but now he's doing just fine. So to conclude this talk, CBT is proven to be the most effective management modality of tinnitus. And if you're an ENT and you want to start CBT, there are some challenges that exist in combining CBT with other otological treatment strategies in tinnitus management. But you have the support, and that is the mission of International Clinical Expert Group, to train and support more clinicians to implement CBT techniques in rehabilitation of tinnitus, hyperacusis, and misophonia. Thank you. I'll go. Oh.
Thank you very much, Anna.
Just let me see how can I make this work.
Yeah, we need to do everything
again. Yes. Okay. Stop share. And I will make Sandra the host again.
Yes, please. I think that's
yes.
Can I go straight to my presentation?
Yes.
I actually had a couple of things I thought that we mentioned before we move on to your presentation, Sandra. So if you can turn on your own camera and then make me the host, so I can turn on mine as well.
Oh, yeah.
Yeah, fantastic presentation, Anna. It was great.
Thank you for sharing. Thank you.
It is great to hear that you can combine the CBT techniques with your in an ENT clinic, which this can be for many of the listeners. It may seem an impossible task, if you like, to actually be able to add additional this form of therapy to your currently busy clinics, but it is fantastic. And so I don't know whether this saves time or not, but the patient, if they are not satisfied, they can come back for more other things and not yet learn how to cope with their tinnitus. And then, so maybe this can be at sometimes a more efficient way of dealing with the patient.
It was important to me that I can solve their problems even more than I can with surgery. You can choose to stop at that point. You do the surgery and you see that with audiometry like that, after the surgery, there is little more you can do with patients. And you can choose to stop at that point, but if you choose to go further and use CBT and use this kind of treatment for tinnitus, I think that's much more rewarding for you and the patient. Yeah.
Fantastic. And this was the same sort of experience we had in audiology clinics, because we used to do all type of different interventions for patients with tinnitus, including sound therapy devices, and then CBT as well as educational counseling, so on and so forth. But over the years, we were trying to make this more efficient and remove the parts of the intervention which were not really doing much. And with the sound therapy element, we actually had to spend huge amount of time with the patient, because it gave the impression to the patient that actually something was supposed to happen to their tinnitus. And there were, I remember we had numerous sessions of adjustments and readjustments of those devices. And but with the CBT, this became more streamlined approach. And in fact, although CBT is quite intensive in terms of number of sessions, but then we cut the sessions that were really unnecessary with regard to the modifying a device, which was, at the end of the day, there was no research evidence that it can actually do anything beyond distracting the patient. So that's, I think, is a good experience in terms of CBT can actually be efficient as well. And in terms of, you mentioned about this safety-seeking behavior in this patient, and which is quite an important thing, that negative thought that you identified, that if my hearing gets worse, my tinnitus will get worse. And if the tinnitus gets worse, I cannot cope. So this is a very damaging negative thought, because this can basically promote safety-seeking behavior in a way that the person starts avoiding a lot of places, including their own workplace or parties or any socialization. So they avoid this in the fear that the external noises may make their tinnitus worse. And so they end up basically making significant changes in their lifestyle to accommodate for that, to avoid noise. And so the more changes they make in their life because of tinnitus, the more important tinnitus becomes. Mm-hmm. And the more important tinnitus becomes, they more notice it. The actual very
focus on it, yes.
Yeah, the very outcome that they were trying to avoid, they actually have to face by use of the safety behaviors. And yeah, excellent. And so did you actually do anything to manage those, the safety behavior parts of it? Like, how did they go in terms of helping them to drop that kind of behavior, if you like?
Well, we created a behavioral experiment in one of those situations. He had a mission to go to a coffee shop with his friends, in the evening. That was pretty loud and he was really afraid and everything. So, it was like a step-by-step approach, but, he managed that pretty well. Actually, I was expecting him to be more, not to bend, to be more fixed in those thoughts and everything, but he managed that pretty quickly. He was determined to solve the problem. And, one of his main concerns was, when he had a baby, he would like to walk the baby, on the street and everything, and not be afraid of his tinnitus, and I think those kind of motivation, just, pushed him further and helped him, just overcome all of these negative thoughts and emotions. So he was a really motivated guy to succeed.
So that two-sidedness that you mentioned is like, on one hand, they were scared of what will happen to tinnitus and whether it gets worse and how they can cope with it. On the other hand, they're feeling that, well, this is not really feasible. I cannot just isolate myself from any noise in the fear of tinnitus getting worse. The next day I may have a child and I want to take them, be with them in a playground, different places. So what am I going to do? Avoid my own children as well. So it becomes like a very unfeasible approach, those safety behaviors.
I like that moment when a patient decides that that is not feasible, when he realizes that, you know, that doesn't work. Everything he's created and the way he's acting, you know, that doesn't work anymore. And it's really a breakthrough moment. The moment he realizes, you know, that, okay, well, this is not a big deal. I will go on with the tinnitus and it won't bother me that much more, you know, in the future. So I like that moment when they realize that, you know, that is important in therapy.
Exactly. And
Yeah.
I think it is quite important to also that you mentioned that, you know, during the therapy, it's not possible for just to tell your patient that, okay, don't do this or don't do that, because this
As
is
much as you want to tell him, you know, like Sandra said, you know what's good for them, you know what they're supposed to feel and how they're supposed to act, but, you know, they have to come to terms with themselves, you know, they have to, you know, change their own mind.
Exactly. They have to change, because we can't change their mind.
No.
They can change their own mind, but then we have to facilitate that. And the experiment that you mentioned, techniques of CBT like behavioral experiments, can actually provide that engagement with the patient in a way that they can go and explore what actually happens. Are there assumptions and the precautions they take? Are they really necessary or not? And then change that process once they realize that some of their fears were not really based on any facts.
In this particular case, you know, he was a very focused guy and he always needed proof. And we've done audiometry a few times and compared the results just to prove to him that his hearing is not getting worse when he hears the tinnitus. When he goes out and after the behavioral experiment, maybe he had the feeling that his hearing was worse, but then we've done an audiometry and that was the same as the one before, you know. And there was like audiometry results and he compared them and he, you know, told me, okay, that's good. You know, nothing happened as I thought it would. So
lovely. Thank you very much, Anna, for a fantastic presentation.
Thank you.
And Sandra, what I'm going to do, I'm going to pass the host to you again, so you can actually share, yes, share your screen. They are so all yours.
All right. Can you see it? Can you see it or no?
Yes, I can see it. Fantastic.
Okay. Everybody's seeing the screen then? All right. My case is a little bit like different from Anna's, and let's see what we are going to find at the end. But it's quite different. But let's see. We are like as you are seeing, we are in 3 of us, but we are in 8 in total. So I'm very like glad to say that I'm part of this group. And we've been learning a lot about CBT and discussing cases every month all together. So that's a big pleasure to be with you all. And going straight to the case, it's a woman of 44 years old of age, and she came to me because she was referred from an audiologist from the north of Brazil, and she was expecting absolutely too much because she was like being seen. She was being seen. Other ENT doctors were seeing her, and nothing was going on. No improvement was getting in her tinnitus. And what she had at the moment when she came to me, before that, actually, what she used to say it was that in her right ear she used to have a tinnitus, and for the last 3 years it didn't bother her. But after she got the hearing aid, because she was in adaptation of hearing aid because of the hearing loss, she started listening to another tinnitus in the other ear, on her left ear, and that one was bothering her very much. And she had a diagnosis of a disease, a myotonic dystrophy disease, that is one of the most between the others muscular dystrophy that has, and it is a genetic disease. And besides that, what she had was 5 years of progressive hearing loss, right? And but her husband just noticed that 1 year after that. So she was what I could get in that with that information, that her hearing was really decreasing, right? Besides that, what she said was she was not getting adapted with the hearing aid, even with all the efforts of the professional over her city. And another complaint that she had was that she was very sensitive to noise. So she was avoiding places, avoiding parties, dinners, everywhere. The best place that she would like to be was in her home. But at the same time, she was sleeping well. She could say that she was used to sleep better than she was at that moment. But okay, there's no complaints about the sleep. And she had suicidal thoughts, right? And total loss of desire in life. So she was absolutely not motivated at all. She was like quite depressed, with no hope in what to do with her life and health and hearing and everything. So she was quite desperate when she came to me. She said that her tinnitus was disturbing her in her daily activities. So the best place that she would like to be was in her bed. So it was like very difficult to get off the bed, taking away her energy, feeling sad and hopeless. So she was giving all the responsibility to her tinnitus, because before that tinnitus, that one after the hearing aid was adapted, she was living quite well. Further with her complaints, what I could get, that she didn't work. She used to work, but she stopped 10 years ago, probably in the same time that when she was discovered with the disease. And this was shocking when I listened her saying to me, doing nothing was what she likes the most. So she was with no complaint about of doing nothing, right? But even though I was like asking her, are you sure that there's nothing that you like to do in your life? And she could say, okay, I like very much watching television, but my hearing loss is taking me this away. And I like reading as well, but I cannot do this anymore because my tinnitus cannot allow me to do it. So because I cannot concentrate in my reading. And but nevertheless, she used to try to work out. Otherwise, she was just like taking care of the house and of her husband. She doesn't have had any children, and she tried as much as she could to work out, because her disease is related to weakness, to muscle weakness. So she could at least do something like to not to avoid the progression of the disease, but something that could like let her like feel better. Her father had the same disease, and her both sisters as well. but her sisters didn't have any hearing problem or tinnitus or anything related to the hearing. And her mother was a bipolar person. She was very resistant to send me the questionnaires, all those questionnaires that Anna's applied. I used to apply to my patients, but she was, I don't exactly know why, but she never answered me the questionnaires. So what I could get from knowing how difficult it was how to cope with their tinnitus and other complaints that she has was using the VAS. So about tinnitus was around 8 to 9. The perception, the loudness of tinnitus, the distress was around 10, and the hyperacusis distress was 10 as well. And talking just a little bit about her chronic disease, it is called Steinhart's myotonic dystrophy. And as I said, there are lots of others myotonic dystrophy, but this one is the most common between the others. And there are like a classification of this disease, and she was classified as the classical one. And when she got diagnosed with this disease, she had at that time 34 years old. So she got me with 44. And what she had that was common to the disease was the weakness that maybe could explain that feeling, that the thing that she would like the most was not like doing nothing or staying in her bed. But in the same time, when somebody says this to me, we need like to be in alert. We need to be aware if there is some depression related, right? She had alopecia and eyelid pitosis. So that was what she was like showing to me, right? And the most problem besides the tinnitus was the progressive hearing loss, right? And in this disease, they usually use this like terminology. Sorry, is the early presbycusis. So this is a young person looking like she was like as she had a worse like age because of her hearing. And the very peculiar thing and like depressing thing related to this disease is that the life expectancy is shorter. So she knew all about this, right? She was aware all about this related to her disease. This was like the hearing test that she brought to me when she first came, and this was done in 2017. And just for you to see how her hearing went after 2 years, right? And she was losing not just like the hearing, but the discrimination as well. So she was complaining very much that she was avoiding getting out, not just because she was annoyed about the noise of the environment, but because she couldn't understand anything that people were saying to her. So it was like a dramatic case, right? And this one was done in the beginning of 2019, and this one was almost at the end of the same year, 2019. So she really goes like she's seeing that she's losing her hearing, right? But different from Anna's patients, she was not like worried about this. She could really understand that tinnitus was not really related to the progression of her hearing, right? So when I have to say that imagine that if I had no like skills related to CBT with a tinnitus patients with a hearing loss that is like related to a genetic disease that we really don't have anything like that you can really do to these patients. Is like that, like you just sit and see her losing her hearing. It was something like, oh my goodness, what can I do to this patient? So as soon as I had in that moment the skills to apply CBT, I cannot look to tinnitus patients differently anymore, because in the past I have to say that I used to look to the cause. So let's look to the cause, and I'm going to treat the cause, and afterwards the patient is going to be free of his tinnitus. So after this knowledge that I got with CBT, I could understand that patient, we can act on like his reactions to tinnitus. So, and basically we could like share in these two reactions. So how loud is this tinnitus to the patient, and how the patient is distressed with this symptom. And before anything was started, and when we, in the meantime, when we were like discussing what to do, in summary, what she got at the end was that she was not coping not only with her tinnitus, but not as well with her hearing loss, with her hyperacusis, with the disease itself, and with the high possibility of die very early, right? And just to you to know that she was being looked. There were psychologists and psychiatrists looking for her. So she was in touch with those professionals. So I was not the only one who was trying to help her, right? But at that moment it was just tinnitus. What can I do with my tinnitus? And when she got to me, she was much more worried about her tinnitus itself than with her hearing loss. And Anna already like explained very much about like CBT. But when we, if you have something to have in mind when you are applying CBT to the patients, is to work on her negative thoughts. So what we can do with all the strategies and all techniques that CBT gives to us to change the way that patients is thinking about lots of things, and mainly of our interest is what those patients are thinking about their tinnitus. And those terminologies, as Anna already said, is like around us when we are like applying CBT. So we don't necessarily need to get to their core beliefs, but as soon as you like get used to it, it's like it gets easy, right, to get there. But if patients understand how they think about how is the way that they think about lots of things, and in the case of tinnitus, this brings like open like our possibilities to change, to give them something like to change their lives. So just for you to understand and to bring it closer to you, here are some examples of her thoughts. So I'm going to read here. I feel desperate with the loudness of this new tinnitus. I don't have what to do. I don't know what to do. I can't control it. It is a bad feeling that I cannot solve it. So she was feeling that she was like with nowhere to go. No, there is no way out. I feel helplessness. And in one of those sessions, just as an example, I asked her, what does helplessness means to you? And she answered, not able to solve because I can't. So she felt in her deep of herself that she was like unable to do anything, right? She was like with no possibilities to get any improvement with anything. I don't control things in life. I don't control things that bothers me. Tinnitus bothers me, and it bothers me to do things that I like, and I cannot even understand what people say to me. This is very interesting. I put this on purpose here, this last thing that she said, because she mixed very much her like feelings and thoughts related to all her complaints, all her symptoms, right? And as I told you, I never could like follow her using questionnaires. And as much as I asked her to answer them, just to like to get something like more objective about her improvement, she was like trying to avoid, but it was her choice. And we ran like 8 CBT sessions, and at the eighth one she asked to stop because she was not seeing any improvement. But just to show to you, and then we are going to discuss, what I had in my hands was, okay, I'm going to use the VAS, that because this is what I can get here very easily with her answers. She dropped like 2 points, right, from 10 to 8, her tinnitus when she first came here. And but as I told you, that's very important to listen what patients are saying. But in the same time, if they don't believe that they are improving, so what can I do? But just to make reflections about this, just for you to understand that she was complaining in the beginning that she was listening for the tinnitus for like 24 hours a day, and like it was like 24/7 noticeable. But at the end she was saying, oh, during the day I cannot notice, I can just notice it like in some moments in the day when the environment is very silent. And she started at that moment to stop complaining about tinnitus because it was not anymore, but she couldn't like really realize that. And as soon as she was mixing very much her botherness related to everything, she started complaining. Actually, she stopped complaining about her tinnitus, and she started complaining about her hearing. And those hearing test that I'm going to show to you, this is like almost the end of my presentation. She did here in my office, and just for you to see, I don't know how familiar you are with acouphonometry, and if a patient doesn't want to answer questionnaires, because there are some patients that like they don't answer, I use like acouphonometry as a barometer, as a way to measure, to see how was the improvement related to CBT. And see her threshold here, when she after 1 month that she came here to me. And after that, she had, just after 1 month, her hearing was really decreasing. And but if you compare here the acouphonometry from the right side, that she could like answer in the first moment when she did, it was like the MML. I don't know how familiar you are with this exam. We can discuss this later. But she was, it was necessary very loud noise to make her not listen to her own tinnitus. And when after the CBT, it was like her tinnitus was like much more under control. So she could answer what she couldn't in the beginning about the left tinnitus, and at that moment she could, and it was more like manageable. It was much more in control. So with like little noise, even if it looks higher, right? If you look to the numbers here, the acouphono, it says here, even if it looks like is as higher as in the beginning, but the important thing is it was much more like under her control than it was like in the first place, right? So that's it. Hashir?
Fantastic, Sandra. If you can give host to Anna so she can put on her camera and then pass it to me. That would be great. Great, Sandra. Fantastic presentation and exciting case. And you've done, so you are also doing some tinnitus measures, isn't it?
Yes.
Beyond the actual questionnaires, you're doing some masking level of the tinnitus, and you trace that out. And from your experience, do they actually match with the visual analogous scale? Their
Yes.
results, they do.
Yes. Like yes. And I think they are very, very reliable. So we can rely very much on them. And it's very interesting when you show to patients if they are not in agreement, or if they don't believe that the CBT or whatever you have done to them didn't like really helped. If you show something, some numbers, some objective numbers, as I'm using with apophonometry or with the questionnaires, and it helps very much, because it makes them like realize that they are in the correct way. So it helped. So it like helps to change their minds.
Exactly, and I think it's very important that because as far as the patient is concerned, tinnitus is an ear related problem. So they go to ENT and audiology. They don't directly go to see a psychologist or a psychiatrist if they develop tinnitus. Yes, if they start hearing voices, they understand that is more of a psychological problem. But for tinnitus, a ringing in the ear or a whistle in the ear, they often believe that this is an ear-related disorder. So they go to an ENT or an audiologist. So if audiologists and ENT can actually provide a therapy like CBT, can actually help them to get a better access to this intervention. And of course, if the patient have anxiety, depression, other psychological disorders, you make a referral before or even during the therapy that you do for your patients. So many of my patients, they already are seeing a psychologist, or they're taking antidepressants, and then they are referred for tinnitus or hyperacusis or perhaps misophonia to our clinic. And if they are not, then when we do the screenings for anxiety and depression and other anxiety disorders and mood disorders, then we will make an onward referral to psychologists. And I think that's providing this type of treatment at the outpatient ENT clinics and audiology clinics can be the link between tinnitus as an ear-related problem to psychology, because many of our patients, before we're doing CBT, patients were given sound maskers, this and that, and they did not end up seeing a psychologist. But once you do the CBT, you also are more aware of the psychological impact of this. You screen for them and refer to psychologists for other aspects of the mental health. So once we started doing CBT, we are referring much more patients to our psychology colleagues compared to if we were not doing CBT. So I think this helps the patient to get access to a CBT focused on their tinnitus, and also a more general psychotherapeutic interventions which is provided by mental health colleagues.
Yes, exactly. I agree. I just don't like when like other colleagues or even the patients think that tinnitus is just a psychological problem, So I think tinnitus is much more than this. It's like a dysfunctional problem, or brain dysfunctional problem. So that is as well with psychological issues, but. I think we need to have this in mind. So CBT helps very much, but not we. This is like the most important thing that I would say. If I could like apply CBT in all tinnitus patients, I think that they would like improve very much. But at the same time, it's not to be like don't stereotype those patients.
Exactly. It's like CBT is basically if the person has tinnitus, but they are not really distressed by it, like it doesn't impact on their day-to-day activities, it doesn't impact on their sleep, it doesn't impact on their mood, then CBT really cannot achieve anything more. They already are not distressed by their tinnitus. But if they are distressed by their tinnitus and the distress cannot be explained by any other distress-producing matters like a hearing loss or depression or anxiety or other things, then CBT for tinnitus can be actually useful, because in both cases that you brought up, there is usually a mix up with effect of hearing loss and tinnitus. So many people get distressed by their tinnitus, but because of the hearing loss that they have. So that's always, an important thing to be addressed right away, as you've done it in your particular patient.
Exactly.
Excellent. And so I also like to just share my screen for and go through a few slides if I can. So it's mainly about the tinnitus masterclass, but this is like, what is a distressing tinnitus? Brian Moore and I published a study in International Journal of Audiology, and where we were actually talking about using an in-depth interview in order to find whether the person has a distressing tinnitus. And a diagnostic criteria for distressing tinnitus is that if it needs to meet at least one of these first three criteria plus the fourth criteria. So either needs to interrupt their certain day-to-day activities, make it difficult for a person to rest or relax, impact on their mood. One of these is enough, but they need also, the distress they're experiencing is not better explained by another disorder like hearing loss, vertigo, anxiety, mood disorders, insomnia, so on and so forth. And I think it is very important for the listeners at home to realize this, that doing the CBT for tinnitus is quite a specialized field, because there are a huge amount of physical sensations that can accompany tinnitus, including oral fullness and vibrations in the ears, hyperacusis. And so even within the tinnitus subgroup, there are when we do CBT for those patients, the actual approach can be different when you are dealing with a Meniere's disease or somebody who has acoustic neurinoma, a brain tumor. So the actual CBT is within that population of tinnitus also needs to be modified to match with the requirement of the patient. And audiologists and ENT doctors are quite in a good place to adjust these CBT principles to the actual needs of the patients based on their symptoms. And this is the free internet-based cognitive behavior therapy for tinnitus, which feel free to use. And the website for this is www.icbtfortinnitus.com. And this is mainly for people who do not have access to a therapist that can help them, or perhaps therapists can also use this between the sessions to give some tasks and refreshing lessons to the patients, so they can actually go and do these modules. And also, we mentioned the Tinnitus Masterclass several times, and the Tinnitus Masterclass is the course which focuses on various topics around assessment of tinnitus in terms of psycho-audiological assessment of it, and then the methodology to use to pinpoint the distress linked to tinnitus, as well as teaching you how to perform cognitive behavior therapy for tinnitus, hyperacusis, and misophonia. And as we already talked about this, I also like to mention this group of international clinical experts for tinnitus, which the aim is provide training and clinical supervision. Because once you learn the CBT for tinnitus, you still need to have ongoing process of support, which usually is done via clinical supervision. And in this group, we have people from different background, like Christina Lasko from Finland. She's a psychologist. Anna, who we already she is here with us today and done this fantastic presentation, is an ENT consultant. And my colleague Gemma Hatton is a senior audiologist. My another colleague, Jules Kurian, is a tinnitus team lead in an NHS hospital in the UK. And Tin Leighton is a psychologist in Belgium. And so we are actually going to do webinars on CBT for tinnitus. This one was the first of the series of ENT perspective. We will have another one on psychology perspective, which Christina and Tin are going to lead. And also we'll have an audiology perspective later on. Potentially it will be next year. So because I want to do the psychology perspective first and then the audiology perspective. And so you'll hear from all of these members of this group. Taryn Richardson is an audiologist and practice owner, which have a strong tinnitus team in Johannesburg, South Africa, and Sandra, who's an ENT doctor, who done a fantastic presentation for us today. So, excellent. So I just wanted to share those ideas with you as well. So, I'm looking at one of the questions here. Trying to read. Can you guys also read these questions?
Mm-hmm.
So this is, I have noticed that quite often these people have been high performance in their adult life or in their childhood. So used to run things for their near ones, take responsibility and control things. So people who have tinnitus and then basically experience distress when they develop tinnitus, they might have had this type of characteristics. So they had lots of responsibility, used to being able to be in control and having symptoms that are uncontrollable, then they blame themselves for not to be able to control tinnitus. And do you guys have any comment on this issue of control? And because obviously tinnitus is something which we can't control. And if people really feel that they must be in control, at least in the things that are matter related to their own life. So, and then they're hit by tinnitus, which is out of their control. How to help?
How to help? Yes, this is an issue that I have to say that almost all patients brings to us, right? So that they don't have control, and that if they could, they just want to switch off the tinnitus and be free forever. And I always bring to them back the question: what do you have an idea what do you control in your life? So, and then actually, I go so, and then after asking questions related to this, do you control the weather? Do you control your thoughts? Do you control what I'm thinking? What do you really control in your life if you have to think about it? So and then they realize, oh yes, I almost not control almost anything. So why I'm complaining about not being in control of the tinnitus. So it's very interesting when and you see changing in their faces. I don't know if you notice this as well, because it's I'm not in control of my tinnitus. So when it was, and they just changed the way that they are looking to us and say, oh my goodness, I'm complaining about this, but I cannot control almost anything in my life. So this is one approach that I usually come with, and I think it helps. I don't know about Anna and Hashir.
Yes, of course. A lot of patients have issues with control, and they want to control the tinnitus also, and they come to the sessions very determined, to solve the problem and get in front of it and everything. But you know, it's at first maybe they're even resistant to the therapy itself, you know, because they want to be in control of everything that's happening during the sessions. So, you know, we're struggling a bit. I mean, in the few first sessions, but I think they realize that what Sandra said, you know, there are a lot of things they could actually control, and tinnitus is probably not one of them, and they should focus on things that are up to them, you know, and their
Yes.
emotions
And
and the
another
thoughts.
important thing, yeah, sorry.
Yeah,
Another say
that is up to them, you know, how they what they feel and what they think and what they do as a reaction to tinnitus. That is up to them. So we can change that.
exactly.
I'm sorry,
And
Sam.
sorry. I just was about to say that another question that I usually ask related to the control itself is, what does it mean to you? Why is so important to be in control of everything, right? So when we bring up those like reflections, I think they change the idea about those things.
Exactly. Like what does it mean to you if you do not control your tinnitus? And so that you can explore further fears of lack of control and the huge value that they give to control. And then during the course of the treatment, as you mentioned yourself, you know, these can be addressed. And so I think we took about 90 minutes for this webinar, and I think it was quite long. And so if you guys do not have any further comments, I think we covered a lot of grounds. And the next seminar and webinar is going to be CBT for tinnitus, psychology perspective, and which I invite here everyone to actually take part in that. Yes. So this is CBT for Tinnitus webinar series from me in London, Anna in Belgrade, and Sandra, Sao Paulo. We hope you enjoyed this program and have a fantastic evening. Goodbye.
Goodbye. Thank you very much. Thank you.
Thank you, everybody. Goodbye. Yeah.